Good afternoon, everybody. We'd like to welcome you to this lunchtime session, a BANNFU webinar on the topic of growing a neonatal neurodevelopmental follow-up service. We've got a lunchtime break and a break for most of you all in your busy days, full of very esteemed speakers and very interesting topics. BANNFU is a special interest group of BAPM, and we are a multidisciplinary group comprising of psychologists, therapists, neonatologists, community pediatricians, parents. We've got a big parent group, and various other professionals who are part of our MDT group. And our aim is to improve long-term outcomes of all babies. And we also want to disseminate good practice to improve care for all our premature babies. We've got 5 topics, and in our first topic, we've got Anna and Betty. So Anna Lukens is the lead physio for the London Neonatal ODN. She's also the lead physio in my unit at King's, and she was appointed alongside our occupational therapy and speech and language leads to start the multidisciplinary neurodevelopmental service, complementary with us, the neonatal consultants. Betty is the lead for occupational therapy, physiotherapy, and neonatal speech and language therapy for children and young people at the Royal Free and Camden. She works clinically at the Royal Free and has been heading the neurodevelopmental follow-up service for high-risk infants at the Royal Free and UCLH for many years. She's also a founding member of EI Smart, which I'm sure a lot of you are aware of, which focuses on working together with parents to improve early intervention for high-risk infants. We've then got Susie, who's going to talk about raising the, we've then got Hilary, who's going to talk about developmental assessments. Hilary is actually part of our executive team, and she's also a neonatal consultant at Cambridge, and she's also one of the leads, co-leads for our research work stream at BANNFU. We will then go on to a topic which is raising the profile of a neurodevelopmental service. And Susie Sweeney, who's the director of the London Neonatal ODN, she's very experienced as an operational leader and leads an exciting program of work to improve the outcome of our preterm babies across the region and has been instrumental in trying to raise the profile of BANNFU alongside with BAPM and trying to improve services as well. And lastly but not least, we've got Olivia. Olivia is a mother of a 26-weeker who's now 3 years old. And she spent a long time in 3 different neonatal units. And her daughter has multidisciplinary input from various professionals. And she's an experienced parent through the neonatal care pathway. And she's going to talk about what parents hope from a neonatal neurodevelopmental service. So I shall now pass you on to the first speakers, who are jointly Anna and Betty, who are going to talk about developing an MDT service.
Thank you, Anusha. So as Anusha said, Betty and I have put together a presentation just to start off by talking about how we could develop an MDT service. We have, hopefully you can see my slides okay here. So we're going to split it into 2 parts. Betty is going to start with why do we need MDT in follow-up, and what each of the roles are of the MDT team. And then I'll be coming in to talk about how we've established an MDT approach at King's, and what our kind of learning points and the evaluation points are. So hopefully will help any of you guys that are looking to hopefully develop one yourselves. So Betty, I'll hand over to you.
Thank you so much, Anna, and thank you all for inviting me to contribute to this talk today, and just to thank Anna, who actually did all the work on this very beautiful presentation, and I've just added in a small amount. So we have very little time, so I just have a few slides to go through very quickly. And firstly, why do we need a multidisciplinary team and follow up? Well, we have the NICE guidelines, and before that we had BAPM telling us that developmental follow-up of children born preterm should happen at various time points, and particularly up until 2 years. And in the NICE guidelines, they mentioned specifically physiotherapy, occupational therapy, speech and language therapy, and other professionals needed in early intervention. So what are we doing in follow-up and thinking about early identification, access to early intervention, all of this leading to improved neurodevelopmental outcomes? We know the evidence about the first 1,000 days. And next slide, please, Anna. We just have a quick look at, why is early intervention important? And this is really, I think, the reason that you want your MDT team in the follow-up programme, because we know that the first 2 years of life are considered critical for development. There's lots of neuroplasticity, much more in that period of time. And we also know that early experience shapes brain development and the environment that the baby's in. And again, your MDT, physio OT or speech therapist can work very closely with parents on thinking about what kind of environment and enriched environments and what kind of interventions may be helpful to babies. Now, of course, there's lots of evidence about remapping of neural pathways in those early months. Next slide, Anna, which just continues about these critical periods of brain development and thinking about it's not just follow-up for preterm infants, it's also the term babies with neonatal stroke, and thinking about the evidence there about the most plasticity being in the first 3 months of life for those babies with neonatal stroke, and often they're not even identified at that point in time. But again, with good surveillance programs and follow-up, we should be able to identify those babies earlier. Okay, Anna, next slide. So just a little look here at the skills that the various therapists will bring with them. And physiotherapy and occupational therapy have some areas of overlap, for example, neurodevelopmental assessments, such as, Prechtel, the Hammersmith, the Bailey developmental assessments, the Brazelton neurobehavioral. And then physiotherapy will specialise more in gross motor and muscle tone, posture, but also be involved in early intervention. And then things like plagiocephaly, torticollis, respiratory is available in some units, and neurodevelopmental follow-up. And again, you see similar in occupational therapy, but more specialised skills in early intervention to promote cognition, social, emotional and sensory motor skills, promoting positive sensory experiences, and again, neurodevelopmental follow-up. And our speech and language therapy, offering specialist intervention and assessment in feeding, swallowing, and very pleased to see communication. And that's something that sometimes we feel that our speech therapists maybe get assigned just feeding, but this early communication hugely important as well. And of course, they're all totally interrelated, feeding and communication. Dietetics, again, are specialists in clinical nutrition, improving and supporting the nutritional status of infants, looking at growth assessment, introduction of complementary foods, specific dietary requirements, and then transition to home with babies with nasogastric tube and so on, and following up in the community. And we know again that feeding, we've heard from our parents at our last meeting about the huge stress and difficulties many parents experience who have babies at home with feeding problems. Next slide, Anna. And I think this is my last slide, just to mention, again, so there's very strong evidence for the use of standardized tools, and there's been several studies showing to use just a screening test means that we will miss about 70% of problems in this high-risk population. And when we think about Prectal, it's not just to predict cerebral palsy. In fact, the General Movement Trust now are slightly moving away from that, because they know that with early intervention we can change movements. And so we're particularly focused using that technique on early intervention. And I think this is very much a key role for physiotherapists and occupational therapists, analysing that movement and seeing how we can change it. But of course, the Prectal and Hein recommended as the gold standard in that Novak and Morgan papers. I'm not going to say too much about the Bailey, given that I have an interest in the Bailey, and I will leave it to Hilary to be an independent person on what she wants to say about it. Anticipatory guidance is huge for us, and I'm really interested about what Olivia will say later. But we feel the huge added value of a therapist in the follow-up clinics is to not just to be able to do the assessments, but also to be able to look at what the baby is working on at that point in time, to be able to provide anticipatory guidance where you're thinking about what the baby might do next, to be able to give that guidance to parents and support that child's development. And I think that parents have told us very clearly, but we'll hear what Olivia says, they don't just want someone doing an assessment. They want the assessment to be used in a way that will help them for intervention. So again, that early intervention is, I think, a key reason why you would want a MDT follow-up team. Anna, back to you.
Thank you, Betty. So now we know why we need follow-up and why we need an MDT approach in follow-up. Anusha asked if I could present what we did at King's College Hospitals in setting up our MDT approach. So across King's College Hospitals, we've got 2 sites. We've got Denmark Hill, which is a level 3 surgical unit. And then we have the Princess Royal University Hospital, which it was a level 1 unit until recently. It's now been redesignated to a level 2. So we wanted to set up clinics across both sites, and it would be for our local infants that met high risk criteria. Previously, because of capacity, they were able to provide a 2-year appointment with the neurodevelopmental neonatal consultant. So the babies were being seen at 2 years, but they weren't getting any of those earlier appointments with therapists, and they weren't necessarily having standardized assessments prior to this point. And we've just heard about why it's so important to have those standardized assessments early on, so that we can identify any potential problems early and help with that early intervention and provide that support for the families. So we were really lucky that we had some funding approved for physiotherapy, occupational therapy and speech and language therapy clinical lead posts, and we came into post just over a year ago, about 1.5 years ago now, so that we could try and set up these new neurodevelopmental clinics. We set up a bit of a working group to discuss how they would work, because we wanted to collaborate obviously with the neonatal team that were already providing a bit of support. But also we wanted to collaborate with the community teams, because this of course was going to impact on potential increase in referrals and things like that to the community teams. But hopefully with those increase in referrals, because they're happening earlier, it would reduce the burden on the later need within the community. So we were really lucky. We've got a brilliant relationship with our community teams, and they've got some really good work going on with early intervention. So any kind of infants that would crop up that would potentially have difficulties within our clinics, we could refer, and they would be able to pick them up quickly. So we started clinics in January 2022. So we developed this pathway. I've taken this from our pathway just to show what we were aiming for. So all the infants that met high risk criteria, so this was in line with the NICE guidelines. So our high risk criteria was infants less than 30 weeks. We also had a catchment of less than 1.5 kilos, just because we felt that some of those sort of 30, 31 weekers that were quite small, we also wanted to capture them as well. And then we would also include infants that had things like surgical neck, herpes simplex virus, complex congenital heart disease. So lots of the risk factors that the NICE guidelines mentioned. So they get referred from the neonatal unit at the point of discharge. We provide a information leaflet to the parents and talk to them about why follow-up is important to try and improve attendance. And they would be initially seen at 4 months corrected gestational age. They would then be seen at 8 months corrected, 1 year corrected, and then 2 years corrected. And we've got a few different professionals in each clinic. This was mainly related to capacity and how we felt the infants, what the needs were at the different time points. So at 4 months, we have physiotherapy and speech and language assessments. And what we would be looking at is doing our rectal general movements assessment and our Hammersmith. And then the speech and language team would be looking at things like feeding and communication. At 8 months, we have physio, OT and speech and language. And again, at that point, we might be repeating some assessments like the Hammersmith maybe, or looking at different motor assessments. Speech and language do the PLS5, which is the preschool language scales. And then at 1 year, we were due to have all three of us again, but because of a secondment opportunity, physio had to come out of that post. But the occupational therapist and speech and language do the Bailey's assessment at 1, and then it's repeated again at 2 years with the neurodevelopmental consultant. And so the main aim from this clinic is to classify the infants into different kind of criteria. So if the infant's doing really well and nothing has come up on our assessment that we're worried about, so there are no current concerns, we would just provide some developmental advice, give some activities and anticipatory guidance so that the parents know what to continue to look out for and they still feel well supported. If we did notice that there was some developmental delay, so maybe some immaturity or some difficulties, we would provide that early intervention and that developmental advice, but we would also then do an onward referral to the community teams for early intervention. And it might be that they're referred just to one team. If it's just a motor problem, they might go to physiotherapy, or it might be that they're referred to all therapists. And then if there was actual abnormal neurology identified, so if we're noticing atypical tone, or if we've got kind of abnormal fidgety on rectal and an abnormal Hein, at that point we would make sure we are discussing with the neonatal consultant team and discussing whether we feel an appropriate referral would be to go to onward to the community paediatrician. We would also then be referring to the community teams so that they can provide that early intervention. So in terms of the evaluation, what we managed to do, so we collected the data from January to August, so it was about 7 months in total. We will be continuing to collect the data, but this was what we managed to get prior to the BAPM conference, which was in September. We took a poster to the BAPM conference just to show what we found. So in those 7 months, we had 111 infants, which totaled 182 appointments because lots of them had come twice in that time period. We had a relatively good attendance rate, actually, given that we had lots of issues with kind of admin and the general setup of clinics. We were expecting it to be slightly worse. So we had 73% attendance rate, could be much better. And we are working on doing lots of preparation in terms of preparing the parents prior to discharge a little bit more. So making sure they're aware of the importance of the clinic and why it's really important they're attending. But of those 27% that didn't come, only 15% of them were not brought, and actually the rest of them were unable to attend, so just needed to reschedule the appointments. So of the infants that did attend, we found that 80% of them were actually doing really well, so 89 infants, and there were no identified neurodevelopmental concerns for these infants. So we provided lots of anticipatory developmental advice and guidance as per our protocol. But as much as 20% of the infants, so 22 over a 7-month time period, did show new concerns that hadn't previously been identified. So some of these infants were also already under community teams if there were concerns raised immediately from the neonatal unit. But we actually picked up 22 new infants that hadn't already shown difficulties, and that at that 4-month or that 8-month appointment then did start to show concerns. And so they were referred to the community teams and provided with the early intervention and support that they needed. So we were, that does then mean that about 20% and 22 of these infants in quite a short time period were referred for early intervention, and they were able to access that early intervention, which previously, prior to having these clinics, they wouldn't have had, because they would have been waiting until their 2-year appointment. So that's really positive so far, that we've managed to start those earlier referrals, and we'd like to look at the ongoing data to see how that changes and whether it continues along a similar kind of percentage and rate. We've been evaluating the clinics, and we're looking at whether we feel the time points are appropriate. It might be that because often infants are going home earlier than term age, sometimes those first 4 months are a really long time for the families to wait. It might be longer than that if they're going home prior to term. So it might be that we do an earlier time point as well, or that we provide some kind of group or outreach support following discharge. So we're looking at kind of at what point we're doing referrals from each clinic appointment, and whether we've got the right whether we feel we have the right MDT within that clinic as well. One thing we have spotted is that because we don't have dietetics in clinic, actually a lot of the time questions do come up about weight gain and about feeding, and so we would really love to get dietetics involved, and we're in discussion with them as to whether that's something that they can join in with us. And my colleague Becca Murphy, she's looking at leading with a parent satisfaction questionnaire as well. So we want to hear from the parents as to whether they're finding this clinic helpful, and what they're gaining from it and what they would like from it. And then longer term, when we've been running it for a little bit longer, we'd like to look at the outcomes and actually compare the outcomes now that we've got this new clinic to what they had previously. So in summary, an MDT approach is really important. Although we do have lots of crossover skills as therapists, we've also got lots of independent skills, and we've got our own specialties. And it's really important that these infants are having assessments from each of the MDT team, so that we can provide these highly skilled assessments and then recognise those infants that need that early intervention. The use of the standardised assessment tools do show high predictive validity. So using the standardised assessment tools is helpful in clinic rather than just using any old assessment. And that with our evaluation of the MDT follow-up clinic, we did actually find that 22 infants over only a 7-month period already had that access to that early intervention. So we're really quite proud of that, because that wouldn't have happened previously. But we will be continuing to evaluate the outcomes and looking at parental experience and feedback. And just a very quick massive thank you to the rest of the neonatal therapy team and the King's Neonatal Neurodevelopmental follow-up team, because we've all been working on this together and everyone's put so much hard work in. So thank you very much.
Thank you, Anna and Betty, for giving us a very insightful look on how to grow a service and evaluate it at the end as well. If you have any questions, we actually have Pip and Fran at the end with Angela, who will be able to answer your questions. So if you can hold on to them, I will now introduce our next speaker, who is Hilary from Cambridge, who's part of our BANNFU exec team.
Sorry, just give me a second. Slide. Can you confirm that you can see the slide and hear me okay?
Yes, we can.
Yes.
Thanks,
Yeah,
Hilary.
thank you very much. So, so thank you and good afternoon, everybody. I'm Hilary Wong. I've been asked to lead this session on developmental assessment. So a little bit about my background. I've been interested in neurodevelopmental follow-up since I was a registrar, and I've completed a PhD on looking at the validity of developmental outcome reports on very preterm infants. And I've joined BANNFU a couple of years ago, really to continue on this journey and to meet and learn from others. So before I start the talk, I think I need to acknowledge the proper experts among you who have been carrying out developmental assessment for years and decades. And I actually do honestly feel quite underqualified to be leading this session. But what I hope to do is to reflect on the theme of this webinar, which is growing a neonatal developmental service, and to open up a conversation really, so that wherever we are on this growth process, we can share our experiences and learn from each other. So what I'd like to discuss and cover are firstly factors to consider when planning or expanding developmental follow-up assessments and follow-up program. I will be referring to the NICE guidelines several times over the course of the talk as the national recommendations. And then I'll signpost you to sort of the more commonly used assessment tools in the UK. So what are the factors to consider when planning a developmental assessment or more broadly a follow-up program? And these are not exhaustive by any means, but these are really just my 4 key factors. So firstly, we need to consider why we're doing this. What is the purpose of the developmental assessment? And it will in turn influence the next point, which is when should we be assessing the children? Thirdly, what are we assessing? So in other words, what is the outcome measure that we want to ascertain? And lastly, and potentially arguably, the most important factor is the resource availability. So developmental follow-up assessment is multi-purpose. Of course, fundamentally, it's a continuum of good neonatal care. I think that's a no-brainer. We do this because, like Betty said, we want to, for the children at high risk, we want to ensure that the developmental needs are met. And if any problem is identified, that we can provide appropriate and timely intervention so that we optimize their developmental progress. We need to have reliable findings and prognostic information to be able to provide ongoing support to the families. But I also think that we need unit-based and population-based outcome information so that we can conduct service evaluation, benchmark to plan services to understand the impact of neonatal interventions for quality improvement. When should we conduct assessment in order to meet these multiple purposes? And I think here there is a little bit of balance to be considered. It needs to be early enough so that we can identify the developmental needs and provide timely and optimal care for the individual child. If the developmental outcome is used to evaluate the quality of neonatal care, then the assessment also needs to be relatable to the perinatal events or intervention. And what I mean by this is the later the assessment is, often more likely that other confounders such as socioeconomic factors will come into play and influence outcomes. We know that the later the assessment is, it's also often associated with increasing loss to follow-up, so particularly in very mobile populations. But on the other hand, the other side of the balance scale, the child needs to be old enough to allow for a meaningful neurodevelopmental assessment. We know that there is ongoing continual developmental and brain maturation processes that sometimes affect the diagnostic accuracy of findings judged early, and that actually for cognitive or language or behavior impairments that are very subtle, it may only become more apparent at older age. So there is a little bit of a balance as to finding the optimal time for the right assessment. So taking all of these into account, the NICE recommendations is for repeated and sequential follow-up visits. So the recommendations are 2 in the first year of life, between 3 to 5 months corrected age, and then the second by 12 months corrected age. So these are age corrected for gestation. And then a third visit that consists of a detailed face-to-face developmental assessment at 2 years corrected age. For children born less than before 28 weeks gestation, the recommendations by NICE is for another assessment to take place at 4 years. That's uncorrected age. The third factor that I'd like to consider is what are we assessing? So again, the list here are problems we know children who are born preterm are at slightly higher risk of developing. So these really should be what we should be looking for. And depending on our individual expertise, we may be more comfortable and better placed at assessing some of these more than others, and which is why the MDT approach is so important. So, for example, we may also have to rely on our community pediatric colleagues to conduct ADOS assessment for children for autism spectrum disorder. But again, going back to the second point, the child needs to be old enough. The fourth factor I've mentioned is looking at resource availability. And I actually find this quite a difficult point to discuss. I don't feel like I necessarily have a global view, and it's really quite difficult to generalize. But clearly, the follow-up program in each locality is unique in order to meet the needs of the local population it serves. And there are very wide demographic variations throughout the country. So, for example, in areas where a large proportion of the population do not speak English necessarily as their first language, then developmental tools that can only be administered in English will not be that useful. The geographical setup, I think, needs to be considered, and it's a big influence. So, for example, in East of England, we cover a very vast area. So we do not here have centralized follow-up services, although I know some other places too. So I guess, needless to say, all follow-up program, whether it's purely for clinical purposes, but also that in order to capture data for quality and service evaluation, requires dedicated and trained staff, the ability to track patients, the ability to perform data management and analysis, and in essence, require financial and logistic support to be able to sustain long-term. So the practicalities of developmental checks, and again, this is taken from the NICE guidelines. So it suggests that recommends that at each visit, we explore parents or carers' concerns. We take growth measurements, ensure that visual and hearing checks are done in line with the national recommendations. We conduct appropriate developmental assessments so that we carefully evaluate and address any concerns raised by parents or carers, and if any developmental problem is suspected or present, to refer the child on appropriately for further investigations and support. And so let's just focus a little bit more on developmental assessments. So in general, we would recommend using a formal developmental assessment tool, like Betty has mentioned earlier on. And in the NICE guideline, it's certainly recommended to be performed at the 2-year visit. Of course, many of us, particularly the pediatricians in the audience, we are taught developmental assessment in the forms of checking against milestones. However, without the use of a formal standardized assessment tools, such assessment is often purely based on clinical judgment and is highly subjective. And in some studies have been shown to lack the sensitivities to pick up the subtle developmental problem, particularly in the cognitive domain. So broadly speaking, assessment tools that are available can be classified as standardized developmental or neuropsychological assessment tools, or screening tools. So standardized tools like the Baileys, like the WIPSI, are considered the gold standard, but typically will require training. They tend to be more time consuming, and they can be expensive. Screening tools such as the Schedule of Growing Skills, Ages and Stages questionnaire are designed for universal surveillance. They tend to be cheaper and quicker to administer. They require less training, but when used in a high-risk population, there is a risk of a low negative predictive value. So I'll just like to signpost you to an article written by Dr. Merchant on behalf of BANNFU that's published a few months ago in Pediatrics and Child Health. And this article really beautifully covers everything that I've mentioned and more. And I've lifted this table directly from the article, listing the developmental tools commonly used in the UK. And I'll just highlight the one that's been mentioned in the NICE guidelines. So at 2 years, NICE recommends that as a minimum that the Parker R, which is a parent-completed questionnaire for language and cognitive development, is used. And if there is a diagnosis of cerebral palsy, that the GMFCS is used to classify the severity. At 4 years, the recommendations are for the use of Ages and Stages questionnaire for general developmental assessment, the SDQ, so the Strengths and Difficulty questionnaire for behavior, attention, and social emotional problems, and the WIPC for IQ testing. Again, if cerebral palsy is present, to use the GMFCS for classification of severity. I'd also like to show you this slide that one of our BANNFU members, Claire Markov, who is a neonatal physio in Newcastle, shared with me this morning. She has asked me specifically to mention that please kindly do not take any screenshot or share this more widely, as she's still conducting the analysis. But this is the result of a survey that BANNFU has done on follow-up services and collected data from 154 units in the UK. And this particular slide shows the results of the specific question on what measures or tools each unit in the UK that has contributed a response to this questionnaire uses. And you can see here highlighted in the bright purple is the commonly used tools, which are the Bailey scales, the Parker R, and the Badger 2-year questionnaire. And I think I'd like to point out here that the Badger questionnaire, if used on its own, is not actually a standardized assessment tool. In Cambridge, so locally, we use all three of these highlighted ones. And I know from correspondence within BANNFU and also certainly hearing from Anna and Betty that other different units uses different tools and utilizing different MDT members within the follow-up services will use something slightly different to draw up different skills. So I'd just like to end on a personal reflections, really, to think about how we're doing. So this really are just my personal reflections. So I often ponder whether we're meeting the parental expectations and how best can we communicate the developmental assessment findings to parents. And I'm really looking forward to Olivia's talk later on a parent's perspective. I also often ponder on the types of outcome measures that we collect and ask the question, are we really capturing the right and meaningful outcome? How can we capture functional outcome and potentially parent-reported outcome, similar to that they use in surgery, which is PROMs, parent outcome measures. I know locally in Cambridge, we struggle to follow up beyond the 2-year age group. And I don't really know how many services have really implemented the 4-year follow-up assessment. If you have, congratulations. I really love to hear from you and to see how you have set this up. Finally, I do think we do need to get feedback on outcome measures, outcome data at the national level. We certainly have the infrastructure with the use of BadgerNet, but at the moment, NNet provides coverage of whether or not 2-year outcome assessments have been done, but not necessarily the findings. So I'm just going to stop talking now, and I'll love to hear any thoughts you may have, and also potentially participate in sort of the Q&A sessions later on in the webinar.
Thank you, Hilary. That was very insightful and really illustrated the variety of tools that we all have to use as neurodevelopmental teams, but also highlighting the data, the amount of data we have to enter into ANNAT in order to capture all the babies that we see. I think we've got time at the end for questions, so if that's okay, we'll take your questions at the end. We're now going to move on to Susie. Susie's from the ODN, and she's been a great support to BANNFU on trying to improve services alongside with BAPM and trying to improve our follow-up rates as well. So I'm just going to hand you over to Susie now.
Thanks, Anusha. Hopefully everybody can see the slides. So thank you for inviting me today to really raise the profile of neurodevelopmental services. I'm really pleased to share my experiences and some of my thoughts really on how to really promote the service at a time of tremendous change in the NHS, to enable us all really to make the best advantage of some exciting developments happening across local infrastructures, which will help us to raise the profile even more. So just a very quick bit about how we work in the London region. As most of you probably know, neonatal care is now delivered through operational delivery networks and has been for about the last 10 years. We cover the whole of the M25 London region, which for us means that's around 13,500 admissions of premature babies each year, and a large proportion of those babies will access the brilliant services of our neurodevelopmental follow-up teams. We also now span and link in with the 5 emerging London integrated care boards, so working very closely with them now to help them shape their clinical priorities going forwards and how to make the best use of their local commissioned funds to improve the outcomes for our population based on local needs. The fantastic thing about the network is that follow-up, neurodevelopmental follow-up, is key in so many of our work streams that we're attempting to support, from operational performance to the workforce to parents, and that integration of the services across the patch. And of course, as we've already mentioned and heard already, that data is a key enabler in that, and without the good data, we don't know how well we're doing, and that data informs all of our policy and process going forward. So it's really important that we get that right. Oh, my screen has frozen. Oh, there we go. So this slide here really shows you how the neonatal ODN is working across that whole sort of life course approach that we've heard about already. So thinking about, you know, from early beginnings, from fetal medicine, linking into antenatal care, place of birth, and then right the way through the early neonatal care services, going out into potentially paediatric care, community care, and then of course at the very end we've got the neurodevelopmental follow-up. And we're working very closely and have done for many years now, and I think it's taken us probably about 10 years to get to the position that we're in now, where we can start to think about making some improvements, some real concrete improvements in our pathways of care, supporting the transformation that needs to take place in many parts of our service, but including neurodevelopmental follow-up as well. So absolutely key and intrinsic follow-up services in showing new commissioners just how important this service is and why we should be embedding that MDT approach. So how did we do it? Well, I suppose, as I've said, it's taken us about 10 years to get to this position. We set out really with a number of key levers that we can use to support improvements to services. And of course, you know, at the very top of that is the support of parents. So probably around 5 years ago, we actually went out to parents and asked them what did they want from their neurodevelopmental service. And I expect Olivia will probably tell us a little bit more about this in her talk. But certainly the parents that we spoke to very much appreciated that one-to-one, face-to-face follow-up, but also the variation in different practitioners that were able to talk them through any sort of issues with their baby. So following that review and audit, I was lucky enough to be able to undertake national audits across the country. So I got to visit, as part of a wider NHS review, lots of other services across the country. And it was very obvious there was huge variation in how we are delivering this, not only in London, but in the rest of the country as well. And we also knew that our 2-year developmental follow-up data, as delivered by the NNAP, was not looking very good and had remained consistently red for many, many years. It was very obvious that, you know, we need to change that. So we've now got this opportunity through integration with maternity services and paediatric services, much more closer working now, that's really highlighted the importance of neonatal services, but also the services that are delivered as part of that continuation of their pathway. And we've got really great opportunities now to think about prevention. ICBs are being set up very much with that in mind. That's one of their golden threads, that prevention through early intervention, you know, not only is better for babies and families, as well as the increase in follow-up up to 4 years, but also there are some significant financial challenges across the NHS, and we can work together through that integrated care to help mitigate some of that risk. Of course, there's also huge focus, and quite rightly so, on equality and equity of provision, making sure that each neonatal network has an inclusion strategy, and to make sure that we are delivering services where we reduce the variation and make sure that everybody has an equal opportunity to access neurodevelopmental services that they need. So in working with those new ICS footprints, we are effectively taking away some of the boundaries, the local boundaries that we've had to work with in the past that have perhaps hampered those follow-up models. And we're now starting to integrate more with local commissioning. As you know, neonatal care is currently a specialised service, and that will delegate as of April next year. So ODNs are supporting that process in that delegation, but it also means we're in a really good opportunity and a unique place to explain to new commissioners as they come into the system that actually they really want to invest some of their money in a really well funded and commissioned MDT approach to follow up. So we've been lucky enough to work with our specialised commissioners to identify funding for a 1-year fixed term project manager, who I hope is on the call today. And he'll be working very closely with all the providers in London across the 26 and 27 units to help embed and standardise the follow-up processes, working closely with BANNFU and BAPM colleagues to really embed those best practice models, and to help trusts identify their own local coordinators, because we know it's very important to make sure that we're not missing any babies, and we really need to improve the data capture through Badgernet. So one of those key outputs from this project manager role will be to look at how we get data from the various parts of the system where we know follow-up is currently being done, and get that back into the system in a very clean and robust way, so that we can really start to analyse that in much more detail and start to develop strategic business cases to help trusts increase their provision for the service. So some of you will know that we've had additional funding through the long-term plan and through Occupational to increase numbers of allied health professionals, and I'm very pleased to say that our brilliant AHP leads in London are starting to work with trusts now to get money into baselines and to start recruitment of these professionals. So I hope very soon we'll be able to see some of the wonderful AHPs coming into post and really reinforce that collaborative and innovative way of delivering local services. We will also be looking at developing some London guidance to help providers start to embed these roles and improve their own local processes to support that. And we'll be agreeing sort of local catchment areas based on mothers' postcodes, so that hospitals start to own babies and you know, have that ownership and establish the right place for those babies, one, to be repatriated to, but to ensure that we're actually picking up babies for follow-up in the right place that's suitable for that particular family. And then lastly, of course, we know the huge importance of research in all of this. So once we have our lovely robust data, we can then start to show and develop some really detailed cases, working and aligning the wider health system partners. So also bringing into things into play such as the PMRT, and child death reviews, so that we are getting a whole system-wide approach to shared learning and understanding what the emerging trends are. Because obviously we're under huge scrutiny as neonatal services to look at our recommendations from the critical care review, Ockenden, the GIRFT, Kirkup, that whole closer working piece between providers, and in having a very collaborative approach to the whole neonatal pathway with follow-up at the end of it, where it will be able to support some of that closer working and make sure that we as ODNs can then link back the research outcomes and analysis back into national policy to make sure that it improves and informs the clinical delivery of services going forward, and ultimately those improved outcomes for neonates and their families. So just to quickly recap, the main key things to think about when starting and in enhancing any service is to make sure that you've got babies and families at the heart of that service, and that service planning, when it's done across boundaries and taken as a life course approach, we think will have the best opportunity for really improving service delivery. Of course, now we've got this wonderful opportunity to work with wider system colleagues to make sure that nobody is forgotten about, and work across those innovative systems where there are no boundaries now, and to really embed that continuous improvement and learning. So I've just put my details there. I'm very happy to share the slides and take any questions at the end.
Thank you, Susie, for giving us a really good oversight and overview of how ODNs work together with specialty groups and the wider ICSs as well. And I think, the key to this is actually ODNs working across the whole of the country together in order to be able to map out the services, to signpost us to the relevant services that we need to refer babies onto. Thank you very much for that. We will now move on to Olivia, who is the mother of a delightful little girl who was born at 26 weeks, for her kind of views and hopes from a follow-up service. Thank you, Olivia.
Thank you. So first of all, I want to say how grateful I am for all the care my daughter has received thus far, but I do feel passionately that the follow-up service can be improved. So I asked fellow parents who spent time in neonatal their thoughts on the follow-up service, and here's a summary of their findings. So there is a large postcode lottery, so access to community services are not always uniform, and often parents are not aware if their child can access or has been referred to services such as physio and dietitian, etc., until post-neonatal, or when they maybe happen to speak to another parent and they find out that these things are possible. So the communication, I feel, that between allied health professionals is not always aligned in different areas, and it can be challenging and quite triggering to have to try and research this yourself, and also to have to update each individual professional about what's happening with your child, because sometimes all the information isn't held centrally. So for example, at a physio appointment, my daughter's physio doesn't always know when the next follow-up appointment with a cardiologist is. Do you appreciate this is probably should be happening, but in my experience doesn't always happen. So access to health visiting services. So I thought it was only my experience, but I've heard from lots of parents that there's a great discrepancy between parents being allocated a health visitor and those who've been forgotten about due to their child having a long stay in hospital. So health visitors could be a key link between neonatal and allied health professionals, especially if, in my case, I was very aware of the fact that my child needed extra physio, OT, dietitian support, but and also from mental health point of view, it would have been really useful to have a health visitor, which I know sounds very basic, but I didn't have one and still don't. So then leading on to, or based on that, so mental health support for parents. So it's very difficult to access follow-up services if you don't know about them, but also if you're dealing with trauma from neonatal. So I think that's why it's imperative that there is the multidisciplinary approach to it, and that the follow-up services are in place. So Other parents suggested that follow-up services are not always the norm for babies born after 28 or 30 weeks, or if they were born at a certain weight. So that was just an observation. My daughter was born at 26 weeks, so that didn't apply to me. Further on down the line, support for access to education. So it was already mentioned about the 4-year follow-up by Hilary, I think. So further on down the line, it's always a fight, especially at the minute for me with a 3-year-old, for the 4-year follow-up. Or making sure that the follow-ups are happening and making sure at the minute we're waiting for the referral to the neurodevelopmental pediatrician, but that's going to take a long time to try and make sure that these assessments are naturally taking place at certain points. But it's great to hear from Anna and Betty that these should start to take place. So solutions. So what some parents were saying was, so I'm a teacher, so we have WAGGLE as one of our acronyms. So it's what a good one looks like. So it's good to hear that Kings seem to have something that's working really well. So I think it's something that does need to be rolled out definitely. So personally, I would have appreciated to have a discharge meeting that would have included signposting to services, a discussion about who were the health professionals who were going to be linked to my child and who could possibly be linked in the future, and what I should do if I did perhaps think that there was an issue. I have a wonderful pediatrician, or my daughter has, and wonderful cardiologist, but just in case parents don't know, or they want to know who they can contact, it would be really good to have lots of signposting and to know who your health visitor was. In my case, the health visitor kept on contacting us when we were in hospital, but then we didn't have any follow-up after hospital. So I think mental health support for parents while they're in neonatal and post-neonatal is essential. So even if there was a perfect follow-up service in place, it can be challenging to access all of the support if the mental health of the parent is not great. Further on down the line, it's imperative that parents have help with EHCPs and education. And lastly, I just want to say that the support parents receive in neonatal is normally incredible, but it can feel that you've been abandoned when you leave neonatal. So knowing that a uniform MDT is being developed is extremely welcome news. And I've just written some notes based on what I've just heard from some presentations. So going back to what Betty said, so I personally find that assessments which took place in hospital were not always passed on to community professionals, especially if we transferred hospitals or trusts. So in my case, we transferred trusts, and then when we went back to our trust, all the information wasn't passed on. But I also appreciate that was in 2019 and 2020, and maybe Badgernet and things like that have helped to improve that. And going back to what Anna was saying, I think using Badgernet is imperative. And I find that, yeah, when we're transferred, not everything was transferred, and that parents felt that when some assessments were taking place, that the information wasn't transferred to everybody that it was needed to be transferred to or like shared with. So that's my main points, but I look forward to answering any questions and any other topics which come up. Thank you very much.
Thank you, Olivia, for highlighting key issues which are actually vital to the improvement of our follow-up services, especially in the hospital as well as out of the hospital and ongoing as they're getting older till beyond the 2 years landmark age. I wonder whether we should now move on to answering the questions, and there are several questions that are on the chat. And if you wanted to ask any questions, if you can just turn your camera on. We've got Pip and Fran, who will be asking the questions with Angela, answering the questions with Angela.
Thank you, Anusha. And thank you. Anna has answered some of the questions in the chat already, so thank you for doing that. But let me just pick up sort of some of the questions in the chat first of all, while people are thinking, but do put your hand up if you'd like to ask a direct question. So Catriona Ogilvie from The Smallest Things asks, when concerns are found at follow-up and children are referred on, are parents then experiencing long delays or placed on waiting lists? I think that probably varies across the country, but I don't know if Anna and Betty, you want to have any comment on that?
I think you've nearly answered it, Pip, by saying it varies a lot throughout the country. So I'm really lucky working in Camden, and we have a really good community service in MDT, and we have the 6-week KPIs. So, but I do know that if you live in neighbouring boroughs, even very close to where we are, you can wait a really long time for physio. You might never see an OT. You might wait a year for speech therapy, and that's just down the road. So, as Olivia said, the geographic postcode thing. Don't know, Anna, if that's...
Yeah, I completely agree. It definitely is variable. I've worked in a couple of different places, and it's been variable depending on where I've worked as well. I think I mentioned that we were quite lucky that we've got a really good community team, that we were able to liaise with them as we were setting up the service and almost set the expectations that these referrals might be coming through. So they could almost anticipate that potentially they will get an increase in referrals, and that helped them to then think about how they were going to manage it. And we've also got, within one of our community trusts, they've set up an early intervention group, which is specifically for referral from this clinic. So they're lucky because they've got capacity to be able to do that, whereas some community services are much more stretched and don't have the capacity to put the time into the early intervention services. So I think that's another thing, that as part of our network roles, we are not just engaging with the acute units, we're also engaging with the community teams, just to highlight how, if they do provide that intervention earlier on, it will take the burden away from the child when they're a little bit older. There will be less of a need at that point. So again, that is something that we are trying to work on, but unfortunately it is variable across the country.
Thank you, Anna. I wonder if, Susie, whether you've got any comment about the kind of new integrated care boards and things, whether that might help some of these pathways from acute into community referrals.
Yeah, absolutely. I think, we've got a good opportunity now to think about those processes across, primary, secondary and tertiary care and, onwards. And I think with ICS holding the budget for everything across their particular patch, they've now got, greater authority about where that money is spent. And it's up to networks like ours, with the support of providers, to work with them collaboratively to make sure that they're putting the money into the services where it's needed, so that it does reduce that variation, whilst improving outcomes. And certainly, in London, and I'm sure in the rest of the country, it's very similar in how it's developing. We are delegating those services from the 1st of April in London, and we will be working in partnership with the London ICS to highlight exactly where we think they should be putting their funding. So I think it's a really exciting time to make those changes. So we'll be pushing really hard for that.
Thank you. Betty, you had your hand up.
Yeah, it was just really to add in that, there's an opportunity now, isn't there? Because there is a redesign of services. And I really love our model where the therapists on the NICU and neonatal units are also doing the follow-up. And so there's real continuity for parents. They don't have to repeat their stories. And if the baby has more complex needs and needs kind of intensive therapy, then we do transfer to our child development team, and we ensure that happens very kind of quickly and seamlessly and so on. But for the babies who need general follow-up and advice to parents and support for development, we manage all of that in our routine follow-up. So I just think that's a nice model for parents, because the relationships are there from the NICU. And I think that makes a huge difference. Again, Olivia, thinking about mental health issues and all of that. So it's a model I like.
Thank you. There's a question here as well about are parents' mental health needs and attachment interaction with babies considered by follow-up services? And I think, Olivia, you mentioned that too. And I think increasingly, I hope they will be. But I wonder, Betty, again, whether you want to comment on that, or Susie.
Susie, I think, was going to say something. Yeah.
Oh, well, it was just to say that that does, the follow-up visits do provide us with a really good opportunity to support parents in signposting to be able to access mental health initiatives and strategies. And one of the things we're doing is working with our lead clinical psychologist to look at a London model for providing perinatal mental health services and actually being able to access potentially in those follow-up clinics, because we've got, you know, parents coming in at regular intervals. It's a unique opportunity to be able to help identify at an early stage families that might need that additional help.
Thank you. Olivia.
Hi, just sorry, back to the mental health, because it's really important to me. So personally for me, the in terms of like what I was saying about the discharge meeting or making sure that you know signposting, I think that would be imperative. That would have been imperative for me, or would have been really useful, that because I felt as if we were kind of abandoned. So if I had have known that the support was going to be in place, that would have helped my mental health. So although people are saying, yes, should mental health be part of it? Yes, but it would have helped the mental health to know, okay, you're leaving neonatal, you've had all this support all the time, and then these people are going to be the support. And if in the future your child needs these things, this is who you contact, and maybe having a main contact, which I know may sound really basic, but I feel we were just so excited to be getting discharged that maybe that was forgotten about. And then the reality of life, of going home and feeding not working, or something happening, or weight gain not happening, and not having the support there, meant that my mental health wasn't as good. And then that maybe wasn't as good for my baby. So I think it's really important to be considering that as well. It might be a natural thing to think about, but it's really important.
Thank you. Yes, and I think the NICE guidance did recommend a kind of discharge kind of information and signposting, and having a named person, but I think that is implemented in different ways, and it's still a work in progress. But Anna, what did you find with your service?
Yeah, no, I was just going to say thank you for highlighting that, because I think it's such an important point, and I know that within our service we always catch up with the parents before they go home, so the therapist will provide some of that discharge information and sort of set expectations, but actually I think doing it as an MDT approach would be so much more helpful. I think a lot of the time it probably is to do with capacity and kind of which services you have on the neonatal unit, because not every unit is lucky enough to have all therapists and a psychologist and things like that. But definitely, I think that's a really, really good feedback, to have a think about having that pre-discharge meeting and kind of getting so that you feel you've got that support already.
Yeah, I agree. For example, in our case, it was that we were in 3 different neonatal units, and the last neonatal unit that we were discharged from, we were only there for a few weeks, and it was for feeding and growing. So we had, you know, the level 3 care with they did have all that, but then when you go to maybe a level 1, they don't have it, but then you're being discharged from there. So there is discrepancies between the levels as well, but I do understand about the differences. So yeah, thanks.
Thank you. Fran.
Pip, I've got another question coming in. It follows on from our chats about NICE guidance, but it's really taking it up a few years. It's a question from Cavi in Barnsley. What is the provision for 4-year follow-up? Should it be done by the community paediatrician? And there seem to be some funding issues. I think that's probably one of the biggest understatements that we've heard today in terms of funding for 4-year follow-up. And I don't know if any of the panel members here would like to talk about their experience of 4-year follow-up. I have nothing useful to add to this, contribute to this, other than to say, oh my goodness, this is a very difficult area. We are not doing 4-year follow-up here in Oxford. We've been talking about how it might be done for the last couple of years, but it's
Sorry, we seem to have lost Fran, but would anyone like to pick up on talking about 4-year and funding? I mean, Anna, you kind of talked about it as a possibility.
Yeah, I think Anusha will probably be able to talk more about it. It is discussions that we're having, isn't it, with the community paediatric team.
Yeah.
But it's not something that we've been able to start straight away.
I think the difficulty here is being able to engage with the different community services, like where we are. We've got about 3 different sort of areas to kind of work across with, and there's such different setups, and it's quite difficult to get them on board, but it's not impossible. So it's a work in progress at the moment, and the funding is the main problem at the moment in terms of 4-year follow-up. But I guess, you know, we need to get the 2-year follow-up absolutely right first as well, and move on to 4-year as well.
Olivia, I think you had your hand up next.
Yeah, just to say, my daughter's 3, and the thoughts of even, trying to get the 2-year follow-up sorted was really difficult. The 4-year one, I think, is going to be really challenging, but really essential, especially access to education, EHCPs, looking for extra support, having all that evidence ready. I keep on getting told that it's a wait and see, we'll see, wait until she's after 3. Now she is 3. You know, so it's really something that I would really encourage people to try and fight for. I do understand the funding, but for me personally, to have the evidence for education is really difficult at the minute, although I have all the reports from different professionals. But to have a up-to-date one report available, or one assessment, would be really useful for me at the minute for education.
Thank you. Betty?
Olivia's already said it. And Olivia, I was really interested because you said you were a teacher, and I'm very interested in when children enter reception, you know, they all have that kind of universal, or every child has an assessment, don't they? And I think that I suppose when I hear people talking about the 4-year-old, I'm a bit worried that it's not joined up with education enough, and with the education and healthcare. And this is where we really have to have an integrated pathway, that we in health shouldn't be talking about it alone. We should be talking about it with education. But you're a teacher, so you know, would have probably a much better idea than I do about that. But that's my feeling where we should be going with a 4-year-old, that it shouldn't be an isolated thing in health. It needs to be together with education.
Yeah, I completely agree. I was just going to say that I think it's what Katrina's going to say from the smallest things, that they have the Prem Aware Award. So at the minute for schools, the assessment mightn't take place until the end of reception, because they might be trying to gather all the evidence. So I feel it's like dead time, wasted time. So at the minute, my daughter's in nursery, and they're saying, okay, so she's going to be in nursery for another year. So we'll gather all that evidence because she's in non-compulsory education. Whereas I know my daughter will need extra support in school. We already know that. She's already had all the interventions. But if I left it and didn't push for it, it would be waiting until she's in reception, until she's in mainstream, until all those resources are wasted, for lack of a better word. And then she would have already had reception when she could have already been in a specialised setting. But I have a feeling that's what Katrina's going to say, so I'll let her come through.
Olivia, can I just ask one question about that? Where do you think the barrier is? Is it health or education, or both of us working together?
I would say that it's probably education, in terms of councils not wanting to give EHCPs and money, and also then more money in terms of EHCPs, in terms of wanting to do the assessments, but also in terms of some areas don't have sufficient placements available.
Right, okay, thank you.
Yeah.
Angela, you had your hand up next, and then we'll go to Katrina and Louise.
Thank you so much, and thank you for this webinar that was really, really interesting. To all of you, thank you for putting your slides together, and for other people that are joining, thank you for joining. Olivia especially, thank you very much. So I'm very interested in the 4-year-olds, and yesterday we had a meeting at our clinical service provision work stream from BANNFU, and one of the main topics is the 4-year-olds, and we want to do something about it, and we don't know what to do. I keep getting these patients coming back to my clinics after 2 years, because you you've just said, brilliant, done, Bailey's 2, great. And then at 3 years and at 3.5, you get all these phone calls from these parents all in distress saying it doesn't match. I mean, this child is now in preschool, the school teacher is saying this and this and this. I'm worried about autism, I'm worried about ADHD, I'm worried about everything. And you go back and you look at the tests that you've done, and they're completely fine to us at 2 years. So there's a discrepancy between the two and the 2 that we're doing and the 4 that they are. And so we're kind of work in progress, as Betty says. And I mean, we need parents in that group. So if you want to join, that'd be great. I've got some of the parents that are coming back all in distress. They come and join me because we really need to set this right. We need to decide what to do in the 4 years. So we need to do what tests. I don't think the NICE guideline is telling us exactly what is needed. I think that to do our very specific psychology tests. Maybe it's not what we need. So we really need to sit down, write it up again, go back to NICE and see if we can just either send a letter, opt out from NICE on this, and then do a different thing from BANNFU. So thank you for highlighting this. And another big issue about the 4 years is, are we going to delay entrance to school for all the preterms? Are we not? So is that beneficial or is not? And the evidence is not there to tell us. So I think big issues on the 4 years. So thank you for picking this up. And just to let you know that we're already setting up that working group if any of you want to join. Thank you.
Thank you, Angela. Katrina, you had your hand up next. If you'd like to put your camera on, and that'd be great. Thank you.
Hi, yeah, thank you. It was really to echo some of Olivia's comments. I'm a parent of 2 boys born prematurely. I'm also a children's occupational therapist by background. Used to work in neonatal care before my children were born preterm, and set up the smallest things, particularly to look at supporting families and children after they leave hospital. I just wanted to pick up on the points around joining up between health and education, and absolutely Olivia's right, that's what parents tell us all the time. They feel very much like, you get discharged from health and then you go into education, or you've still got problems going on in health, but that's not being joined up with education. Very much the difficulties around EHCPs is very much with the local authorities and funding. Again, that's what parents are telling us, and particularly just picking up on that last comment around the discrepancy around the 2 years check and then children starting school. Parents often say to us, they passed their 2-year check, and I think that's how parents see it. It's sort of a bit of a pass or fail, and they're so happy, I think, at that 2-year stage to be finally out of the neonatal journey, only to find that when their child starts school, actually difficulties start cropping up that they weren't aware of that could be an area of need. So it's so great to see all this work going into the sort of the early years follow-up, but it's looking at how that's now extended up to that 4-year check, but also that joined up between health and education, which is just not there at the moment. But there's lots of people working in this area, and I'm really, really happy to see that work being done. But just wanted to sort of, reiterate some of the things that Olivia has been saying as a parent. It very much chimes with my own experience, but also what parents tell us as a charity.
Thank you. That's really helpful, and it is such an important area and something to work towards. And I think, there's definitely something that we would like to see improved in the coming years. So thank you very much for bringing that up. Louise, would you like to go next?
Yeah, I've just got a couple of points. I do think that there's a whole cohort of babies that we do miss out on, certainly for those IUGR small for dates babies, even at 37 weeks. Even if they're at 1.5 kilos, there are seen a lot of those children going through the system that actually do need a lot of educational needs as well, because the brain development, and we seem to have just completely missed a cohort of babies. And I know we're looking up to 30 weeks and it's a start, isn't it? But it's just, it's quite massive. But I've got he's 20 now, but I found the service extremely disjointed. And there seems to be no communication. There seems to be a barrier between who wants to talk to each other, and of course the funding barrier. When you come from health and into education, but there just seems to there seems to be a bit of a system failure to me in communication, and it is very postcode lottery as well up and down the country. What perhaps your experience in London is getting better, but it certainly isn't in the north for me. So we get a lot of parents that are saying this, and I just don't know. We're talking about all the good things going on, but we need to make it across nationally, don't we, to make it improve those services. And I'm not sure whether there's something that needs to come out of, that we need to do as a national thing to push for all these children, all the neonatal children, because everybody should have access. It shouldn't be, because it just is massive. There is massive difference. You wait until you get into a school system, and it's having to be the reception teachers that are picking up the problems, isn't it, Olivia? And I know it that myself. Your health visitors, where are they? We've lost them. We seem to have lost health visitors. I never saw a health visitor. Couldn't get a health visitor. And I'm a neonatal nurse. So, I can imagine what it would be like for parents who aren't in that position. But it just seems to be, I've got a 20-year-old child and we're just talking about the same things that have been going on for years. And it is a communication issue, I think, as well as, there seems to be just no proper process in place for everybody, like a nationally agreed process almost. It's just so disjointed. So I suppose I'm putting out the question there. Is there something that we need to do further from BAPM, or, I don't know, or the nice guidance?
Thank you, Louise. Yeah, and I think one of the reasons that BANNFU, kind of came into being was to try and standardise things across the whole country, and to have involvement from services and practitioners and parents across the whole country, for exactly that reason, to try and drive something nationally, get people involved nationally, to standardise the process so that every parent and every child born prematurely would have the same opportunity of early intervention and follow-up. So thank you for kind of highlighting, and we really hope that that we can kind of contribute to that kind of improvement and levelling across the country. Anusha, you had your hand up.
Thanks, Pip. Thank you for highlighting that, Louise, because actually that was one of the things I was going to echo, is through the clinical services provision work stream and the mapping exercise that we've done, is being able to identify the gaps right throughout the country in the kind of streamlining of services from the hospital out into the community. And hopefully through that will be highlighted through a gap analysis of looking at all the various services, and BANNFU will hopefully be in a position to be able to advise on that. But it's in progress.
It's not easy, is it? And it's a massive project. And I do get it. The system's huge. The NHS is huge, isn't it? It's a massive organisation, but it's trying to put it all together so it's not disjointed, because we just don't seem to have that process, do we? Where we're all getting this, and it, logically, you look at it, it isn't difficult, but it's just the funding's not there, and where are the people? There's a whole, and it feels a bit of a system failure for me. Sorry, Olivia's there.
Thank you, Olivia.
So yeah, I agree with what Louise said. I was just going to say that I think it might be a funding issue, but I think in the long term it would save a lot of funding. So if the initial support was in place, then, like I was saying to Betty, that it probably would save, for example, further physio, OT, etc., if it was all put in place. And I know Anna's already echoed that. So it's another example of where we could actually end up saving money by putting money in at a different sort of point. At the minute, I'm fighting for more speech and language support for my daughter at age 3. So I know that because we won't be able to get it at the minute, it's going to mean that she's going to need to have a lot more when she gets to school age. So that's just another example of when money could be saved, because at the minute we can't access it because she's only been given 6 sessions and she's non-verbal. So yeah, that's just an example of when we could actually be saving money if the gap between the 2-year and the 4-year was, if we found that, okay, this child needs extra support, put the support in early, be better for the child, better for the NHS in terms of funding. So it's a win-win situation, really.
Thank you. Yes, I completely agree. There's just one. There's another question in the chat, which is a slightly different point. But there's a question about whether there are any statistics on the percentages referred to speech and language, OT and physio at the 2-year follow-up. I don't know, Anna, if you want, or Betty, you want to kind of speak into that?
So from our clinic, because we've only been running the therapy-led neurodevelopmental clinics for just under a year now, we haven't been able to capture that data at 2 years for the ones that have started with us for the follow-up. But we do have, because our occupational therapist has joined Anusha and the team in the 2-year clinic, we are getting verbal feedback that now that we're sort of 1 year on, some of the infants that were seen at 1, actually they tend to be doing a bit better by 2, and there seem to be less referrals coming out of the 2-year clinic now, because they're normally already under the right services. So that's definitely data that we are wanting to collect. We just aren't at the stage yet where we can, because we haven't been running it long enough. And just very quickly, I can see that there was a question from someone asking about why 4 months for the first follow-up developmental assessment, which I think we missed. And is that getting a bit late for GMs? Yes. So if I was purely running a physiotherapy clinic, I would see them at 3 months. But because we're also looking at things like feeding and the global aspects of development, speech and language therapy, we're quite keen to see them around 4 months. So what we do is kind of try and see them between that 3 and 4 month stage to make sure they're still at the kind of less than 16 weeks for prectal. But moving forwards, what I would love to do, if we were able to get capacity for some admin support, is for the parents to be able to video the babies at home, send the videos through to us prior to the appointment between that 12 and 16 weeks, so that when they come at 4 months, we can then provide the feedback from the assessment and we don't actually do it in clinic. So that would be the goal.
And
Thank
can
you.
I just
Yep, go on.
add a word about the follow-up, because we've been doing it a very long time, Olivia, or where the question came from. We do see a difference, so that in the early stages, the 3 and 6 months, it's quite often more the physical therapy, so physio in particular, that's where you see the initial delays. And then at 2, you see something entirely different. So we're not referring many children, if any, to physio at 2, because those kind of problems we've picked up earlier. But you begin to see very clearly the speech and language problems at 2, the attention, the hyperactivity, the social emotional problems, which maybe you couldn't see at 3, 6, and even 12 months, but you can definitely see them at 24 months. And that's in a way why in our service we run EI Smart clinics for the preterms in the early intervention. So we're thinking ahead and thinking, these children, we won't wait until they're 2 and then they have some speech or social communication problems. Let's combine the physio, the OT, and the communication aspects in our early intervention and have it very holistic, because we know what's going to show its face at different stages. And you probably found that anyway, Olivia, in practice. So I think we need to change early intervention as well, so it doesn't just focus on one thing. One parent in our EI Smart group said, you know, she felt when she went home with her 24-weeker, there was a different therapist for every part of the body, you know, and that's also not the answer. You don't want to be inundated with, you know, so I think we have to look at predicting what might happen and how we can prevent it.
Thank you, Betty. We're coming towards the end. I know Anusha wants to just close it. Angie, do you want if you can keep a very quick comment, that would be great. Thanks.
Just very quickly, we've been collecting that information about referrals for, I don't know, maybe 20 years now. And it has been changing, as Betty says, it's been changing. And before we didn't have EI Smart, but we did have Betty. So we had different things. So we have data on what input we've been having on this specific therapist along the line of from 0 to 2 years. And we also have data on new referrals that we make at each specific assessment at 3, at 6, at 1, and at 2. If someone is interested in that data, I'm happy to share it with you. This is North Central region. It's about 3,000 babies. So we're happy to share.
I think we'll probably have to close now. I know, Fran, you've got your hand up.
I have. Anusha, thank you very much. Just before you finish off, I just wanted to remind people that on the BANNFU website, there is information in the education and training section. There's some really useful resources there that people might like to take a look at.
Thank you, Fran. Thank you very much to all our speakers for a very insightful day and interesting topics as well. I hope we can all go away with some ideas and maybe some thoughts to sort of plunge into all our individual services. What I'd also like you to do is encourage you all to apply to BAPM, and if you want to join BANNFU, you'd have to come through BAPM. There on our website, we've actually got how to apply to join BANNFU. We've got lots of work streams with lots of interesting work coming out. But thank you very much for joining us on this rainy day, and hopefully you'll become a bit sunnier later on. Thank you.